Hi, everybody. Welcome to this Exploring My Diagnosis breakout session. In this session, we will be discussing Sezary syndrome with Dr. Jennifer DeSimone. First, we're going to hear a presentation from our doctor, followed by some time for questions at the end. Should you have a question that comes up during the presentation, you can feel free to submit it via the Q&A icon at the bottom of your screen, and we will get to questions at the end as time allows. But should we run out of time to address your particular question, please join us at 3 o'clock Eastern time for our open clinical Q&A panel. So now I would like to introduce Dr. DeSimone. Hi, Dr. DeSimone. Thank you so much for being here today.
My pleasure.
Dr. DeSimone is a specialty care physician, board certified in dermatology. She joined Inova Medical Group with 5 years of clinical experience. She has a special interest in management of cutaneous lymphomas, skin cancer in organ transplant recipients, and other complex skin cancers. Dr. DeSimone became interested in lymphomas of the skin because of the rarity of the disease and the need for the greater understanding of its origin and development of more effective therapy. Her goal is to help educate her patients about skin cancer etiology. So with that, thank you so much, Dr. DeSimone. I'm going to turn things over to you.
Sure. Thank you again for inviting me to be with you today. I'm happy to be here, and I hope that I'm able to provide some very useful information. Today, we'll be talking about Sezary syndrome, and here is our agenda for the day. First, I'm going to get into just a little bit of disease background, a little bit of the science behind Sezary. Then we'll talk about how the diagnosis is made. We'll move toward a review of the most commonly used treatments in this disease, and then I'll leave plenty of time for a question and answer period. One thing I should mention is that I did have the opportunity to preview the questions that were submitted ahead of time, and I believe I've covered nearly all of them in the content of the talk. So hopefully that will work well. Okay, so let's start with just a basic definition of Sezary syndrome. Sezary syndrome is the leukemia version of cutaneous T-cell lymphoma. There's a lot of overlapping terminology between stage 4 erythrodermic mycosis fungoides and true Sezary syndrome. The malignant cells in both of these diseases are T-type lymphocytes, and they have very similar marker profiles, which means that when we do very detailed studies looking at what kind of T cells are in the skin or in the blood or in the lymph nodes, we're focusing on CD4 positive T lymphocytes when we talk about both Sezary and mycosis fungoides. The difference is that the cells of origin in Sezary syndrome are called central memory T cells, which means that they circulate centrally or within your bloodstream, whereas the cells of origin in mycosis fungoides are called skin resident effector memory T cells, which means that they're largely locked in the skin. Here's a wonderful schematic that I'm presenting from a paper almost 10 years ago, or over 10 years ago, from Rachel Clark in Boston. And I think it just helps us really get our mind around what we're talking about here with the difference between mycosis fungoides and Sezary. If you see up top in this drawing, this is meant to represent your skin barrier. And this is just an example of healthy physiology of the immune system in the skin. You can see that a bacterial pathogen, like a germ of some sort, may try to get into a crack in the skin. And when that happens, there are immune cells called dendritic cells that kind of grab onto that bacterial pathogen and then help present it or deliver it to the closest skin draining lymph node. Then once that dendritic cell has arrived in the lymph node, there's a priming or a maturation that occurs of the T cells in the lymph node, which results in the production of T cells that have activity specific for that pathogen. And there are two types of T cells that can emerge from that process. One are these skin resident effector memory T cells, and those go right back up into the skin. That's where they live. And so those cells will kind of run surveillance in the skin. And if that same bacteria or pathogen is encountered again, you've already got very specific T cell immunity in the skin to rapidly clear any potential infection. Also, you then have the maturation and development of central memory T cells. These are specific, antigen-specific T cells that are circulating in the bloodstream. When you have a malignancy here, we're talking about mycosis fungoides. When you have a malignancy here, we're talking about Sezary syndrome. So what causes Sezary syndrome? We still don't totally understand. There have been some associations that have been observed with a small list of medications or drugs, but these are associations or clusterings. They're certainly not proof of causation. But just to touch on that, there's a blood pressure medication called hydrochlorothiazide. It's also a diuretic. That seems to be involved in at least worsening or unmasking CTCL and Sezary. Anti-seizure or anticonvulsant medications are potentially associated with this, as are antidepressants or selective serotonin reuptake inhibitors. Sezary syndrome does not appear to run in families per se, and it's not linked to any unique mutation. So very different from, say, breast cancer or some types of colon cancer where individual families have a known protein mutation. That doesn't seem to be the case here. So the most widely accepted explanation is that there's something called an epigenetic phenomenon going on. And what that refers to is the interplay between your genetically predetermined immune functioning and the wide range of environmental exposures that any given individual has been exposed to over the course of their lifetime. And there's some sort of combination there that results in essentially dysregulation of T cell immune functioning. Last picture on this subject. I like this again because we're looking at, it just kind of helps us understand what we're talking about in MF versus Sezary. When you look here, you see the malignant CD4 positive T cell is the cell that's causing the problem in both disease processes. And then this particular picture shows kind of a continuum. But you can see that in these middle panels, we're talking about mycosis fungoides, patch and plaque stage here, where those malignant cells are higher up in the outer layers of skin, tumor stage here, where the cells have moved down into the deeper layers of skin. But then when we're talking about Sezary syndrome, most of those malignant cells are in the bloodstream. There's some percolation of the cells into the skin, but definitely the bulk of the problem is within the blood. So how do these patients present, or how do they look and feel? Well, erythroderma is kind of the hallmark feature of Sezary syndrome, and that means diffuse redness with some scaling or peeling of the skin over pretty much all of your body. This is associated, unfortunately, with really intense itching or stinging. This is severe for many patients and is the biggest problem in symptom management of Sezary. Also, you can encounter swollen lymph nodes. And when we do the physical exam, we're able to assess those lymph nodes in the neck, in the underarms, and in the groin. But you can also have some involvement of lymph nodes internally. Many patients will experience hair loss affecting the hair on the scalp, on the face, or on the body. And because the blood is shuttled to the skin, because of all the inflammation, it takes with it core body heat. And so many patients will describe feeling cold and shivering and chills. Another thing that we see in Sezary syndrome is something called acral hyperkeratosis, which means that the hands and feet on the palms and soles become very, very thick and brittle, and you can develop cracks or fissures, which are painful and potentially can become infected. So those are problematic as well. And then in very advanced stages, you can see a particular phenomenon called leonine facies, which refers to swelling and distortion of the facial features. So here are a couple examples of erythroderma where you can see that the skin is just bright red from head to toe. These are two other patients. Please don't be distracted by these growths here. These are unrelated benign keratoses, but again, you can see that these patients are bright red head to toe. So how do we diagnose Sezary syndrome? Skin biopsy is not as useful as it is with cutaneous T-cell lymphoma mycosis fungoides type, because again, the malignant cells are in the blood, not in the skin. So skin biopsy is traditionally done and it can give us some useful information, but the bulk of our diagnostic info is going to come from an assessment of the blood. And that has to be done in a very specific way. So we draw the blood and you can look at it in one of two fashions. One is you can send it for flow cytometry, and that's what's done most commonly. And that's where we basically tabulate the number of cells that display the abnormal marker profile that is associated and pathognomonic for Sezary syndrome. Another way is to just look at the cells under the microscope, and that's more of the old-fashioned way, and the pathologist can give you a quantified value of how many of those cells look like Sezary type cells, and that's based on their shape and certain specific features that Sezary cells have in terms of how they look under the microscope. We also send the blood for something called TCR, or T cell receptor gene rearrangement analysis. And what that's looking for is the presence of something called a clone. So in the regular physiology that I showed you before, where the skin may encounter a bacterial pathogen, you have an immune response, and you generate a reasonably appropriate number of T cells specific for that antigen to clear the infection. That's the normal physiologic state. In Sezary syndrome or in mycosis fungoides, what happens is you've got some kind of abnormal driver of cellular proliferation. So if you go and you look at the T cells with these specific individual antigen profiles, you'll see that there's this huge amount of T cells that all have this one very specific signature, we call it. And in that case, it is evidence that there's not been this normal development of a reasonable or adequate amount of T cells that's been generated in a physiologic fashion, but instead you've had this really robust, excessive overproduction of T cells with the same signature, and that is highly suggestive of some abnormal malignant driver causing tremendous proliferation of these cells. So that's what gives you a positive result on your TCR. So what are we looking at when we do the flow cytometry? Well, we know that Sezary cells have these specific features. They're CD4 positive, and they tend to lose some of these normal markers called CD7 and CD26. So when we run the blood through a flow cytometry machine, it's basically tabulating the values of these particular marker profiles. And what we're looking for is, what's the ratio of CD4 to CD8 cells? In the normal state, you're going to have both. And you can have a little bit more of the CD4 type than CD8 type, but it shouldn't be more than about a ratio of 4 to 1. When you've got this big overgrowth or proliferation of abnormal CD4 cells, then the numerator in that ratio is going to go way up. So what we see in Sezary is that that ratio is 10 or higher. Also, we quantify how many of these cells are CD4 positive with loss of CD7. If that's greater than 40%, probably dealing with Sezary syndrome. And then lastly, how many of these cells are CD4 positive but have lost the 26 marker? If that's greater than 30%, then that's also a criteria for diagnosing Sezary syndrome. And then we add in the TCR studies that I mentioned. Okay, so transitioning now to treatment. I think it's important to point out that there, frustratingly, is no specific algorithm or any unifying guideline in terms of which medications should be used at what sequence point. We have many different medications to choose from. They're largely equivocal in terms of their efficacy. Most of these drugs will work in about 1/3 of patients. And so the choice of individual approach, or the choice of individual treatment, is really nuanced and individualized and based on the patient's potential bad outcomes with side effects, or their other comorbidities or other health problems that they may have. But it's very different than some other types of cancer where it's clearly laid out how you progress from one treatment protocol to another. Here, it's a lot of individualized selection. Also, at this point, while we're working on it, we don't yet have a lot of ability to predict which medications will be most successful in which people. Again, I just want to contrast that from other malignant processes where we're starting to be able to do some gene profiling on tumors and therefore predict which drug will be the best fit for any given patient. We're not quite there yet in CTCL. We have a couple markers that we can focus in on that can help guide our treatment selection, but we have a lot of work to do. So again, mycosis fungoides and Sezary syndrome, though technically different diseases, they're both malignancies of the CD4 positive T lymphocyte, and therefore the medications that we use to treat these diseases often overlap as well. So looking at the category A drugs, that means the drugs with the best data behind them to support their efficacy, we've got brentuximab, bexarotene, a procedure called extracorporeal photopheresis, the interferons, low-dose methotrexate, mogamulizumab, and then the HDAC inhibitors, romidepsin and vorinostat. Looking down here, and forgive me, these are the National Comprehensive Cancer Network guidelines. Down here, we're looking at not just MF, but Sezary syndrome or MF with a high burden of disease in the blood. If you have relatively few circulating Sezary cells, then the recommendation is for combination therapies as listed in the table above, or you can use some of these category A drugs in combination with skin-directed therapies, and that refers to phototherapy or total skin electron beam or topical nitrogen mustard, things of that sort. Then for patients who have many circulating Sezary cells, again, the recommendation is for often combination therapy or specifically mogamulizumab plus skin-directed therapies or romidepsin plus skin-directed therapies. I also want to highlight the inclusion of the monoclonal antibody alemtuzumab or Campath, which I'll talk about in a moment, and then the immune checkpoint inhibitor pembrolizumab. These are included in the guidelines and therefore valid and indicated therapies for Sezary syndrome. Okay, starting with bexarotene. Bexarotene is in the category of medications called retinoids, which are vitamin A analogs, and they've been used in cutaneous T-cell lymphoma for many decades. These cells basically help abnormal cells start to normalize in terms of how they proliferate, how they differentiate, and also bexarotene also provides some immunoregulation of cellular cycling, essentially. It was licensed in 2002, and this is an oral agent available in capsules. It can be given alone or in combination with other types of therapies. Patients are started at a loading dose of 300 milligrams per day. And in every single patient, it's going to cause two main side effects. It suppresses your thyroid function and it increases your triglycerides and or your cholesterol. So all of these patients are started on not only the treatment drug, the bexarotene, but then also we have to give thyroid replacement, levothyroxine, and then one, if not two types of cholesterol management medications as well. Additionally, we have to repeat blood work pretty frequently to monitor for any dysfunction in the thyroid that's not repleted adequately. We see these patients at the 8-week point after they start on that loading dose, and if there's not an adequate response, then we titrate up by one additional capsule every 6 to 8 weeks. Here's a chart showing the results of 3 studies looking at bexarotene in patients with erythroderma and or mycosis fungoides. And you can see that the reported overall response rates range pretty widely here from 24% to 100% in the study of just one patient. But in my practice, some patients do very well with just bexarotene. Other patients definitely need combination therapy to get good disease control. Here are a couple examples of Sezary syndrome patients treated with bexarotene. This is what I was talking about with that thickening and distortion of the head and neck anatomic features. This is a patient with untreated Sezary. He was treated with just bexarotene and maintained on 1 pill per day with excellent results. Here's a patient of mine who came in erythrodermic, and 3.5, 4 months later on just bexarotene and modification of one of his potentially driving agents in his medicine list, he cleared very beautifully. Interferons. So interferons are substances that we have in our bodies naturally, and they increase your antiviral immune function. They also increase your anti-cancer immune function. If you give them as a drug, it's been shown to bring about a wide range of biologic effects, including enhancing your immune response to malignant T lymphocytes, so that good anti-cancer functioning. It's given in a multitude of ways. There are a lot of different regimens, and again, no clear protocol, but patients are usually on this in the long run. Once patients have achieved really good disease control, you can start to look at withdrawing interferon, but it's typically given for the purpose of long-term immune modification. And the response rates are pretty good, again, widely varied. Overall response rates in a study from Elise Olson ranged from 29 to 80%. Complete clearance ranged from 4 to 41%. It's given as a shot that you take at home Monday, Wednesday, Friday. And the side effects are usually encountered early in the course of therapy. Most patients state that after they've been taking interferon for a couple weeks, it goes away. But flu-like symptoms are the main complaint that we encounter from most patients, where you feel kind of achy, tired, etc. We have to monitor blood work for any dysregulation in your enzymes in your liver and watch your complete blood count, because that can be affected as well. Many patients are given interferon as part of a combination therapeutic profile. So we usually give it either with oral retinoids or with some light treatment with other drugs. So it's not usually given alone. Some patients really can't tolerate interferon, and so we have to monitor people very closely. You can encounter some depressed mood that is significant, so we always ask patients about that. And then in our more elderly patients, it can really impact their cognition, so we have to be cautious using interferon in elderly patients. Okay, moving toward targeted agents. These are medications that work by going after a specific protein and blocking it, whether that is a cellular marker or a specific enzyme. And so they're not traditional chemotherapy. And so the side effects that you encounter with these medicines are very different than what you would get from traditional chemotherapy. So there's not usually hair loss. You don't have a lot of this sort of collateral damage of a cytotoxic drug where you kill off a lot of cells, hopefully all the bad cells, but you're going to kill some of your natural cells too. Less of that phenomenon is observed with targeted agents. They're better tolerated in general. So starting with a medication called a histone deacetylase inhibitor, or romidepsin, this is a medication that you receive through an IV on days 1, 8, and 21 out of each month. It was approved in 2009 for CTCL. It works in about 1/3 of patients. The median time to response is 2 months, and the median time until you progress is about 15 months. The downside of this medication is that it has a very long infusion time. So patients are in the infusion center for, half a day at least. Also, for some patients, not all, but for some patients, the side effects can be very significant, including fatigue, taste disturbance, and nausea. Other patients tolerate it just fine. I've had very elderly, petite women tolerate romidepsin at full dose with virtually no side effects. And I've had younger, more robust people really have a horrible time with it, not be able to tolerate it. So we just have to kind of watch people carefully and see how well they do on these various medications. The next medicine that I'll discuss is Campath, or alemtuzumab. This is a monoclonal antibody targeting a protein called CD52. CD52 is expressed on malignant CD4 cells. So by giving Campath, you can, in a targeted way, kill off some of these malignant CD4 cells. So looking at Campath use in Sezary patients, very good overall response rates have been reported, 86 to 100%. It's given as an injection Monday, Wednesday, Friday, but it's done in the physician's office as opposed to interferon where patients give it at home. And it does eradicate some of your healthy CD4 cells as well. So patients have to take antibiotics and antivirals while on this medication and then for a period of time after they discontinue it. One unique thing about Campath is that the regimen can be very customized based on how patients are doing. So for instance, if you give this medication for 2 months and the patient looks great, you can take a drug holiday. If they start to have a recurrence, you can give a few more doses and just kind of monitor that way. Here are a couple examples from a colleague's paper of patients who had a successful response to Campath, and you can see the before panels are on the left, the after panels are on the right, and there's tremendous improvement in a lot of the erythroderma redness and some of the thickening of the hands that you can see there. Okay, the next drug I'll talk about is called brentuximab, and this is an anti-CD30 antibody drug conjugate, it's called. Basically, it binds to cells that display the CD30 protein, and then it makes its way internally in those cells and causes cell cycle arrest and ultimately cell death. It's given as an infusion every 3 weeks. The overall response rate across all types of CTCL, not just Sezary, is a little higher, is about 60%. And interestingly, how well patients respond to this drug does not directly correlate with how much CD30 positivity they have on their blood work or on their skin biopsies. The main drawback of this medication is that it does cause some neuropathy or sensory disturbances. And in some patients, that can be very severe. And in about 20% of patients, it does not seem to resolve after withdrawing the drug. So we watch patients very closely. We see them every 3 weeks before their infusion and screen them for signs of neuropathy. And if there's anything that is significant, then we will either dose reduce or hold the infusion. Mogamulizumab. This is an anti-CCR4 molecule. CCR4 seems to be upregulated or more prevalent in Sezary cells. The medication is given every week for the first month and then every 2 weeks until the patient has progression of disease. The overall response rate is about 28%. One thing to know about mogamulizumab is that if a patient goes on to seek a stem cell transplant, you have to do a washout period because this particular medication, if it's sequenced too close to a stem cell transplant, can increase the graft versus host disease phenomenon. Total skin electron beam. So this is a form of skin-directed therapy. It's radiation, and the goal is to sort of dust the skin with radiation in a very uniform pattern and to get the entire body surface. It can be administered in one of two ways. One is by having patients hold a series of poses while the radiation oncologist kind of shoots the electrons at them. Or I think more commonly, this rotational method that is demonstrated in the photograph here is used where patients hang onto a platform and they're slowly rotated around while the electrons are administered to get, again, a uniform absorption of the radiation therapy. So the traditional standard dose was 36 gray, but increasingly we've been using about 1/3 of that amount, usually in combination with other treatments. Here's a very recent paper that came out in the JAMA Dermatology, looking at low-dose total skin electron beam therapy as part of a combination regimen for Sezary syndrome. And this paper details 3 patients with Sezary, all of whom achieved long-term remissions, which is very unusual with Sezary, with the addition of low-dose total skin electron beam, which is about 12 gray total, to systemic regimens including extracorporeal photopheresis, bexarotene, and interferon. Here's another paper showing total skin electron beam combined with mogamulizumab. And this paper detailed 2 patients who both had a complete response to this combination therapy and tolerated it quite well. So we'll transition now toward discussions of just pure immunotherapy. Immunotherapy is a term that describes treatments that are designed to enhance the native anti-cancer immune response. So it either helps the body better identify cancer cells and or kind of boosts your anti-tumor immune function in a multitude of ways. So starting with a procedure called extracorporeal photopheresis, or ECP, what this refers to is a type of immune therapy where patients go into the pheresis suite. We place a large bore IV, you take the blood out, you separate out the lymphocytes, you put the red blood cells right back in, but then you take those lymphocytes and you mix them with something called 8-MOP, which kind of causes their DNA to break open, exposing the malignant lymphocyte antigens, and then you pass that blood through an ultraviolet type A light panel, and then you reinfuse that treated blood back into the patient. And so basically what you're trying to do is take the malignant lymphocytes out, break them open using this 8-MOP medication, blast them with UVA so that now you've got exposure of the antigen, like we talked about in the very beginning, of the Sezary, and now you reinfusing it back into the bloodstream to try to allow the patient's natural immune system to better identify and therefore attack the atypical lymphocytes. Here's a patient who's getting ECP. I believe this young lady had graft versus host disease, but regardless, you see she has a port. They're pulling the blood out, mixing it with the 8-MOP, passing it through the UVA panels, and then reinfusing it back into the patient. It's typically given as 2 consecutive treatments, meaning say Wednesday, Thursday. It takes about 4 to 5 hours per treatment, and it's done every 2 weeks most commonly. The overall response rate, again, across a broad range of patients in CTCL is reportedly about 60%. One problem we can run into is being able to get reliable access to the veins. So some patients do wind up requiring a port like this patient. ECP is commonly combined with other treatments like interferon, bexarotene, or total skin electron beam. Okay, the immune checkpoint inhibitors. These are molecules that ensure appropriate immune function by modulating how our immune cells or our T cells get activated in response to any antigens, including cancer cells. So looking here, what typically can happen, or what can happen in the case of cancer cells being able to evade immune response, is that the cancer cell can bind to our T cell. The job of the T cell is to kill that cancer cell and basically shut it down or inhibit it. So what the checkpoint inhibitors do is they come in and they prevent the cancer cell from being able to shut down the T cell, or they create disinhibition of your T cells, resulting in an augmented T cell response against the cancer cell, or basically preventing the cancer cell from being able to hide from your T cell immunity. All the side effects encountered with these medications are of the autoimmune type. Because you're basically tinkering with the immune system and you're making it more primed to attack. And so you can have some attack against your healthy cells as well. And this can manifest as problems with the thyroid, the lungs, the liver, the gut, the lining of the heart, or the blood cells. Any patient who has a history of autoimmune disease should not receive this type of medication. So speaking specifically now about pembrolizumab, this is an PD-1 inhibitor. We know that PD-1, that's a protein, has been shown to be increased in cutaneous T-cell lymphoma. And just to quote a couple studies here, a 2016 study treating patients who had both MF and or 5 patients with Sezary showed that those patients who received the drug every 3 weeks for up to 2 years had an overall response rate of about 38%. This is an expanded version of that study, now looking at 15 patients with Sezary syndrome specifically, published in 2020, which reported a 27% overall response rate. And it's important to know that there was a report of a skin flare, which means that as the patients were on therapy, things got a little worse before they got better. So they developed kind of a worsening of their redness and erythroderma that was finite and self-resolving, but that should be talked about with patients before we embark on this type of therapy. So one thing to keep in mind is that it's hard to use a T-cell based immune therapy to treat a T-cell malignancy. And Dr. O'Malley up at Brigham reported that 86% of the malignant T cells express PD-1, compared with only 16% of benign T cells. So PD-1 expression may actually restrain some of the malignant T cells from growing. And there is the unfortunate paradoxical potential for worsening of CTCL if you're blocking PD-1. So something to keep in mind. That said, there are many different active trials right now looking at pembrolizumab in combination with other drugs because it is an exciting potential option. And then I will just say that in our practice, we've had great success treating several patients with Sezary syndrome with pembro. So it doesn't seem to work that well for patients who have thick cutaneous lesions, but for patients who have, true Sezary, pure Sezary, we've had some good success treating those patients with pembrolizumab. Okay, stem cell transplant. So allogeneic stem cell transplant is kind of the one thing that can result in anything that approaches a cure. The trick is that you've got to get yourself under really good disease control before you're even a candidate for stem cell transplantation. A lot of my patients kind of view stem cell transplant as kind of a last ditch effort, but that's not the reality of the situation. The truth is that you've got to get as much of the disease eradicated or controlled as possible right before you transplant the patient to ensure the best chance of a successful transplantation. And what we do basically is kind of wipe out the patient's own immune system, which has proven to be unable to control or fight Sezary syndrome. And then we engraft the donor immune system, which hopefully genetically will be superior at fighting off Sezary syndrome. So that's kind of the theory behind it. Here's a patient of mine with Sezary before and after his transplant. He's still doing quite well now, 3 years out, requiring no therapy. There's a study by Dr. Dubik that looked at 47 cutaneous T-cell lymphoma patients treated with stem cell transplantation over the course of 12 years. And she found that the incidence of disease progression or relapse after transplant was about 50%. And then among the Sezary patients, the progression-free survival, that means that they hadn't had any recurrence and they were doing well, at 4 years was 73%. Here's a patient pictured above who had, these are photos before the stem cell transplant and then 1 year after, and you can see tremendous improvement there. Okay, the last type of therapy that I'll talk about today, because I've had patients ask about this in the past, is called CAR T-cell therapy, or chimeric antigen receptor T-cell therapy. And basically, these are cells that have been genetically engineered to produce an artificial T-cell receptor for use in immunotherapy. And it's very successful for patients who have B-cell type malignancies, but there are a lot of challenges when you're trying to use, again, a T-cell immune therapy against a T-cell cancer. And I won't get into, this is pretty detailed, but basically the main 3 problems that you can have trying to use CAR T-cell therapy in Sezary or cutaneous T-cell lymphoma is that you can have as you engineer these T cells, they can accidentally attack your normal T cells because the T cell that you're trying to target looks very similar to a healthy T cell. And so you can accidentally create an immunodeficiency. Or you've engineered this killer T cell, but it can accidentally kill the engineered killer T cell. So you can have basically this null scenario occur where the weapon that you've created kills off all of the weapons that you've created. Or then lastly, you can accidentally incorporate one of those tumor T cells into the product. And so you can have contamination of this engineered product that you're trying to use for therapy. So these are pretty major challenges in trying to use what is otherwise a very exciting and effective therapy for hematologic malignancies in Sezary syndrome. But research is ongoing to try to come up with ways to get around these challenges and potentially allow CAR T cell therapy to become something that's effective in treating T cell malignancies, including Sezary syndrome. So in summary, Sezary is a very rare disease. Expert care is critical, especially in the advanced setting. I suggest that you continue to utilize the Cutaneous Lymphoma Foundation resources to try to locate a multidisciplinary CTCL clinic near you, or one that is accessible to you. Please remember that many therapies are equivocal and that the decision to pursue a specific treatment is really complex, nuanced, and individualized. And then lastly, always seek opportunities to self-educate and ask your provider questions about your disease and your care plan. This is a confusing disease. Not a lot is known about it, and you should feel very comfortable asking as many questions as you need to or want to. And I'm sure your provider will be happy to talk with you and answer your questions, starting with me answering questions now.
Thank you so much, Dr. DeSimone. That was wonderful. We really appreciate you being here.
My pleasure. I think I talked too long. Sorry.
No, not at all. It was wonderful. We do have some questions that have been submitted. Okay. And 3 people actually have asked, what do you suggest for nighttime horrific itching?
Oh, I know. It's rough. So this, like I mentioned before, this is the biggest problem with Sezary syndrome. It's very difficult to get to the root of that itch, very difficult to just medicate or mask that itch. The main things that we use are, getting adequate therapy is first and foremost, because if you can shrink down that malignant clone effectively, you're going to remove the itch. But things that we typically start with, I'm sure if you're asking this question, you've already had it, but Atarax or hydroxyzine, that can be given up to 3 times a day, not just right before bed. You have to watch out for daytime sleepiness as a side effect of that. Also, you can use some narrowband UVB very minimally, especially it depends on how inflamed you are, but light therapy 3 times a week can be very helpful in minimizing itch. Some patients will use very low dose, or I've given for some patients low dose naltrexone. That's sort of an opiate receptor blocker, and that can be helpful in itch because the opiate receptors, they're called the mu receptors, can be involved in creating the sensation of itch. So that's one potential thing. And then there's also a medication called aprepitant that can be used in some patients. Hard to get that covered by insurance, and very mixed results. But it's a tough one. I wish that I could come up with some way to help people, because I know how miserable it is. At least I've heard how miserable it is. I don't think anyone knows until they've experienced it. But you start with the hydroxyzine, maybe add in some light therapy if you can tolerate it. Low dose naltrexone is certainly something to ask for, or maybe try to get your hands on some aprepitant if you can get insurance coverage for it.
Okay, great. Thank you. Can I get the COVID vaccine if I am still on CAR T therapy?
No, I think that would be a bad idea.
Okay. Is there a particular time that you would wait between, or is that not really something you can answer?
So we don't know much about how we're just learning about how the COVID vaccine impacts cutaneous T-cell lymphoma patients. And I recently participated in a grand rounds virtual through Columbia and brought up this question to my colleagues, because what I was seeing was patients who had received the COVID vaccine, when I tried to run their flow cytometry panel to gauge their response to therapy, it was completely skewed. That CD4 to 8 ratio that I mentioned that we use as kind of a diagnostic marker and also as a response to therapy marker, 10 and up means you've got Sezary. In these patients, it was like 40. So the the COVID vaccine mobilizes T cells as part of generating immunity against COVID, it's definitely going to trigger some T cell function. So for patients who just have skin disease in cutaneous T-cell lymphoma, no problem, go ahead and get your vaccine. But if you have Sezary syndrome and you're on a T-cell therapy, now is not the time for you to be getting a vaccine. And I'm sure that your provider who's managing the CAR T-cell therapy would say the same thing.
Okay.
In terms of timeline, I mean, I'm not totally sure. It would be based on your response to CAR T-cell therapy. You know, there are a lot of different factors there.
Okay. And does the same apply to the shingles vaccine? We also get that question a lot.
So my response about this shingles vaccine is, I'll just preface it by saying I'm a little bit biased because I only hear from the patients who had a bad outcome from the shingles vaccine, right?
Okay.
My patients who get their shingles vaccine and there's no consequence, they don't come and talk to me about it. But I do hear about a significant number of patients who had a lot of side effects from the shingles vaccine. So I think if you've got, florid Sezary, you may want to hold off on some of these optional vaccinations. COVID obviously is a different situation, but if you've got just skin limited disease, you're probably safe to go ahead and get your shingles vaccine. You may have some side effects, but the majority of people tolerate it just fine. But for patients who have very active Sezary syndrome, we need to be cautious in those patients with vaccines that are, again, quasi-optional.
Okay, thank you. I have developed growths on top of both fingernails and toenails. They are unsightly and annoying. What can or should I do about them? I don't know if that's really a Sezary question.
Yeah, it's hard to know what you mean by growths too. Does that mean that you're having some onychodystrophy or some nail thickening because of the acral hyperkeratosis I mentioned? Nail changes are hard to mitigate at the source. Usually you need to just get on good systemic therapy. The reason that nail changes are encountered is because the inflammation that occurs in erythroderma involves the entire skin surface, including something called the nail matrix, which lives under the skin behind the nail. And so if the nail matrix is inflamed, it's not going to produce healthy nail. It's going to produce thickened abnormal nail. You can put, in some cases, you can put some very high potency topical steroids on the nail area, and sometimes that can mitigate the problem a little bit. But again, there's no nail specific way to address that. You usually need to get at the root of the problem so that you can allow the nail matrix to recover and then generate a healthy nail plate.
Okay. And I know you kind of covered this one, but someone had asked, what other monoclonal antibody treatments are available for Sezary besides MOGA?
So we talked about brentuximab, which is an anti-CD30 antibody. We talked about Campath, which is an anti-CD52 antibody. There are a couple others that are in clinical trial development. CurDL2 antibody, there's a Telemax study open at my center that's investigating that. But the ones that are on the market that we use most commonly were covered in my talk.
Okay, perfect. As a follow-up to your shingles comment, someone asked, can you define very active Sezary in regards to holding off the shingles vaccine?
Yes. So if you still have B2 stage blood disease, meaning if your CD4 to 8 ratio is greater than 10, if your 4 positive, 7 negative is greater than 40, if your 4 positive, 26 negative is greater than 30%, you have active Sezary syndrome and you have a large amount of abnormal T cells in your bloodstream. You should probably be careful about optional vaccines.
How will I know if I am eligible for a stem cell transplant?
So you need to talk to your cutaneous T-cell lymphoma provider. Typically, we only think about stem cell transplant in patients who have advanced stage disease. And then you need to be able to have a good response to therapy to get your disease under control. Also, it has to do with functional status and age. So typically, the upper age limit for stem cell transplant is about 70. So if you're older than that, it's less likely that you'd be a good candidate. But the combination of things, how bad is your cutaneous T-cell lymphoma in terms of stage, how controlled is it with therapy, and then what's your overall health status that would create your risk profile for being able to successfully endure a stem cell transplant. It's a very major medical procedure.
Mm-hmm. Okay. Will the thickening of my skin go away after my treatment?
If you respond to treatment, the skin texture does largely normalize. It may not go completely back to normal, but a lot of that thickening is due to infiltration in the skin of these abnormal T cells. And if you respond to your therapy and your abnormal T cells are reduced, then the skin texture should largely return to normal.
Okay.
Hands and feet get better.
Okay. My skin looks like vitiligo. Is this pigmentation common?
In hypopigmented mycosis fungoides, you can see a picture that some people may think looks similar to vitiligo, yes. That typically is treated with light therapy, and patients respond quite well to narrowband UVB type light therapy in the setting of hypopigmented mycosis fungoides.
Okay. I have several very deep fissures. Is there anything I can do to help this? They're very painful and disrupt my sleep.
Yeah, I'm so sorry. That's another scenario that breaks my heart for patients. This is going to sound kind of crazy, but what I advise my patients to do, just discussed this yesterday with a couple people, is take some super glue, put it right in the fissure, hold the skin together, blow on it until it dries, and that will seal shut those big cracks. That accomplishes two goals. Number one, reduces the pain because it's not going to be pulling. Number two, allows the crack to heal from the bottom up because that tissue is sealed together. So it sounds crazy, but that's a good way to mitigate that symptom.
Okay. Do you work with any alternative health practitioners? Have any studies been done to see how stress may be a causal or causal factor? Have you researched functions of the liver and kidney and how their performance and internal inflammation contribute to CTCL? Kind of a long one, sorry.
Yeah, that's okay. So I encourage my patients to work with naturopaths if they are interested in that. I personally don't have a well-established relationship with a provider in that discipline, but I'm very open-minded to it. It's hard to do a study looking at the relationship between stress and any disease process because it's very hard to quantify stress. Also because you can't have a controlled study. You can't stress one group of people and not stress another group of people. That said, there are a multitude of skin diseases, including psoriasis, atopic dermatitis, and cutaneous T-cell lymphoma, that anecdotally, most providers will tell you does tend to flare when people are under intense, prolonged psychological stress. Not I had a stressful day, but patients who are under intense, prolonged stress. And we think the reason for that is that in that situation, you are releasing natural corticosteroids, which are immunosuppressants, and so you can have a worsening of disease. But again, with the question about looking at inflammation as being potentially causal, it's hard to design a study that fits what you've kind of generally outlined there, but we are definitely looking at markers of inflammation and trying to evaluate why they're upregulated in certain disease states, including cutaneous T-cell lymphoma and Sezary.
Thank you. Do you treat CTCL with full body radiation and courses of interferon injections? That was my treatment for 3.5 years to get into remission.
Yes. So we have a total skin electron beam machine at my institution, and I try to follow the guidelines as they're published by not the guidelines, but I follow the evidence-based medicine as comes out in the literature from my colleagues. That's why I wanted to present those two papers looking at low-dose total skin electron beam, one in combination with interferon plus bexarotene, the other in combination with MOGA. But total skin electron beam, particularly in that low dose, is an excellent skin-directed form of therapy to combine with other immune-based therapies to try to achieve good long-term disease control. So yes, we do. We have a couple patients on that regimen right now.
Okay. This one is kind of a long question. They're asking, what can I do? I am not sure if my prescribed ointments are having an effect in slowing down my disease. Should I leave them on selected parts of the skin and see what happens? I have some small skin tumors which have been stable for over a year with clobetasol. I also have a rash where it seems the ointment I'm going to say this wrong, mometasone
Mometasone, yep.
Sorry, don't stop the progression. The creams may have side effects, and I'm not sure if I should risk them if they show no or little effect. Let me know if you need me to repeat any of that. Sorry.
No, sure. So I think that that is a really specific scenario, and it's hard for me to advise you without seeing you, without knowing greater detail. So I don't mean to pass the buck on that question, but I think you definitely need to go to your prescribing provider and have a long conversation about what is my overall prognosis. Do I need to start to think about different treatment options in addition to just topical steroids? What is an adequate time trial of topical steroids for me? What's my stop date? These are things that only the provider who knows you and knows your history and can see your physical exam can answer accurately. So I don't want to pontificate about what you should or shouldn't do without the benefit of knowing more about you and seeing you.
Okay. Do you recommend Sezary patients join clinical trials?
In certain scenarios, yes, I do. I mean, I think that it opens the doors for a lot of patients to be able to have access to some of our newest and most exciting forms of therapy. Typically, what I do in practice is offer the indicated, FDA-approved therapies, trial the patients on those. If we're not successful in getting the disease under control, then we'd absolutely encourage them to look at entering a clinical trial.
What is the best chemo that I can receive?
So that goes back to what I was trying to say before, which is that most of these therapies are equivocal. So there's not one clear choice that is superior to the others. And it has to be a very individualized decision based on your other health problems, your disease course, multitude of individualized factors that your doctor has to take into account and discuss and explain with you. But there's not one superior treatment.
Okay. I am 80 years old. I've had CTCL for about 15 years. This year it has spread all over my legs, arms, and chest. I'm treating with topical medications. I'm in the sun a lot too. I'm getting concerned. So maybe just looking for some advice.
Yeah, so I think you got to go back to your dermatologist and say, am I moving from stage 1A to stage 1B? And is this more skin involvement than what I can treat with just topical creams? Is it time for me to maybe get some light therapy? Maybe I should get some total skin electron beam. Maybe I need to move to a topical nitrogen mustard. It sounds like you may need to be reassessed, restaged, maybe appropriate to do, lymph node exam, check your blood, et cetera, make sure that things are not progressing internally. And then you may need to switch gears in terms of what your treatment is.
I've been diagnosed with Sezary. Can I then go down to a lower stage?
That's a great question. It depends. So if you had mycosis fungoides and then you went, from stage 2 to stage 3 to stage 4, stage 4 mycosis fungoides and Sezary syndrome are used interchangeably, unfortunately. But if that's the case, and then you get good disease control in the blood, then your restaging could potentially be less. But whenever we talk about patients, we always say, this is a patient with a history of stage 4 mycosis fungoides / Sezary, currently stage 3 or whatever the case may be. But that, that maximum stage is still always part of your history. It depends on, we think of cutaneous T-cell lymphoma as existing potentially in any of 3 compartments: your skin, your lymph nodes, and your blood. And if you are someone who had involvement of more than just the blood, then you may potentially be restaged in response to therapy.
Okay. My grandfather has Sezary syndrome. Do I need to worry that I or my children will get it?
So as I discussed in the etiology section, this is not a hereditary disease.
Okay. What are my options for remission?
Your options for remission are the therapies that we've outlined. Stem cell transplantation is the only treatment option that we have right now that is potentially curative. The others are all aimed at inducing a remission, but all of the systemic therapies that we discussed, the goal of treatment there is to induce a remission.
Okay. And we have just about 5 minutes left, and it looks like we have one more question here. Isn't it very risky to have a stem cell transplant? If they wipe out my immune system and then I can't fight my Sezary, how do I know if it's worth the risk?
Yeah, so that is a complex question, and there are a lot of variables to consider. You need a full consultation with a transplant medicine doctor. Yes, it's very risky. There's risk of death from stem cell transplantation, and so it's not anything to be taken lightly.
Okay. Oh, one more. Do you advise the use of Keytruda and the like immune drugs in Sezary?
Yes, we have several patients who we have successfully treated using PD-1 inhibitors.
Okay, great. Well, that was our last question. We have a couple people saying thank you, Dr. DeSimone. So thank you so much. We really appreciate your time and your knowledge and expertise, and we're just really grateful that you're able to share with us today. So thank you so much.
More than happy to be here. I hope the rest of the day is productive.
Yes, and we do hope that everyone will join us for our next session, which is our sponsor engagement session and a chance to speak directly with some of our pharmaceutical partners. So in the meantime, please take advantage of our guided breath work and stretch break immediately following this session. So we will hope to see you all again soon. And thanks again, Dr. DeSimone.